5 o'clock, is everybody ready? All right. I'll call the Kittitas County Public Hospital District Number 1 Board of Commissioners regular meeting to order. Let's begin, please, with the roll call. Mandy?
Matt Altman.
Here.
Terry Clark.
Here.
John Ward.
Here.
Bob Davis.
Here.
Erica Libanow. Here. Julie Peterson. Here. Scott Olander.
Here.
Stephanie Walker. Here. Rhonda Holden. Here. Ron Erlacher.
Here.
Dr. Hoppy. Here. Amanda Scott. Here. Mandy Olson. Here. And Jeff Holdeman. And it looks like online we have Dr. Kevin Martin.
Here.
Jason Adler.
Yep.
Michelle Whirl.
Here.
Trisha Sinek. She's let us know she does not have a mic working though. Jeff Yamada. I think Jeff's on there, maybe some troubles. Mac Annex. Who do we have on the line there? Do they have a mic troubles?
There we go.
And then Kara Henderson is on. Oh, sorry, go ahead.
Clinic admin.
Clinic admin?
Yep.
Thank you. And if there's anyone else?
Okay. All right, thank you. First up is the approval of the agenda. Are there any changes or additions to the agenda? All right, do I have a motion to approve the agenda?
So moved.
Motion from Erica,
Second.
second from John. All those in favor of approving the agenda, please say aye. Aye. Consent agenda. John, you've had a chance to review these. Hopefully, before they went in the packet, everybody had a chance to review them once they were in the packet. Minutes from May and June. May was our regular board meeting. June was the special retreat. Checks, foundation reports, and finance committee minutes. Any questions or changes to make to the consent agenda before we approve it? A motion to approve the consent agenda. Move. Second. Second from Terry. All those in favor of approving the consent agenda, please say aye.
Aye.
Aye. All right, good. First up, we have a presentation on rural healthcare workforce from Dr. Kevin Martin and Amanda Scott. Amanda, welcome.
Thank you.
You guys are up.
Dr. Martin is really going to be kind of kicking off on the provider side as well. I'm happy to stand as well if that's helpful, but Dr. Martin is on Zoom, and so I think he's going to kick us off, and I'll jump in as well.
Hey, Dr. Martin, you're up.
And you can hear me okay?
Yes.
Perfect. So Julie asked us to do an update on the challenges and successes that we've had with workforce and maintaining access. One of the things that is, excuse me, I'm getting feedback and it's a little disturbing. We've known for a long time that we were going to have a workforce shortage. A lot of you in the room have heard me say that that was some of the work that Don Solberg and I first bonded over 19 years ago, was looking at how we were going to maintain the supply of physicians and in particular primary care physicians. The best data out there right now comes from the American Association of Medical Colleges, the group that really sets the direction for medical education in this country. And in this report from June of 2021, they were projecting based on 2019 data out to 2034, but what they foresaw for 2023 is useful. In 2019, they estimated that there was a physician shortage of 20,000 physicians. By 2034, they were expecting that could be as high as 124,000. Based on their modeling, we would say that right now we're looking at somewhere between 45 and 70,000 physicians that we need that we simply don't have. We all know that primary care has been particularly hard hit. So I'm actually 2 slides ahead of you
Okay, thank you.
because I'm looking at my screen with my notes. And so this is looking at the primary care shortage of 20 to 30,000 currently, and essentially as high as 50,000 in another 11 years. It's not just primary care next. But even if we look at surgery, we go from what was essentially an intact workforce in 2019 to a shortage of almost 10,000 now and as many as 30,000 in another 11 years. Next, one of the things that we've been really focused on is looking at protecting maternity care. So there are about 23,000 obstetricians in the country. The American College of Obstetrics and Gynecology has a job board. They currently have about 2,000 positions posted. So you could say that there's about a 10% shortage now. The JAMA Career Center has 69 open postings in the state of Washington. And when we talk about a shortage of a couple of thousand, we graduate maybe 1,000 every year, but we're also having folks retire at a pretty similar rate. I think the best we can hope for right now is treading water, and AAMC would suggest that we're losing ground. Everybody's easy button is to blame it on the pandemic, but a lot of this arises from issues that existed before the pandemic. Next. So the population's getting older, and as the baby boom ages, we've known for, well, since I was in training that we were going to have resource management issues. I don't think we adequately thought about what that meant in terms of the physician workforce. Current estimate is that 1/3 of all physicians will be 65 or older by 2030. So greater than 1/3 of the workforce is in jeopardy of retirement. I shouldn't say in jeopardy, they've earned it. So what have we done to ramp up our ability to train? Medical school, we have new medical schools. Existing medical schools have expanded class sizes, but the choke point is residency. Residency is where you get trained in your specialty. When we finish medical school, we're all doctors. When we finish residency, we're surgeons and family physicians and neurologists and urologists. The total number of residency slots is set by legislature, and it comes out of the Medicare budget. As part of the COVID Rescue Act, Congress added 1,000 residency slots across all specialties nationally as a one-time increase. There's a lot of colorful metaphors I could use. I'll stick with that's a drop in a bucket. As we've added burdens, the number of times in the last 15 years that somebody has said, we will require physicians to do 1 or 2 hours of education around my pet peeve, or everything about this needs to be documented at every visit, has been a real contributor to burnout. When I first started in practice, you could plan on a primary care physician caring for 2,500 people, and that number is about half that now. And it is a result of all of the things that we've decided have to be done. One of the things that younger physicians have looked for to buffer that is flexible scheduling. And we see that in our workforce. A lot of our providers are willing to take a cut in pay rather than be a traditional full-time equivalent. What that means is that, for instance, we could use 40 physician FTE in primary care in Kittitas County to adequately meet the needs of the population, it's going to take us 60 or 70 people to do that. Some of them will work full time, but some of them will want a fractional equivalent. And all of this, the regulatory burden was increasing long before COVID. In a 2019 MGMA survey, 76% of respondents cited increasing regulatory burdens as impacting their ability to practice medicine. More than half stated that the forced administrative overload is contributing to the likelihood of their retirement in 5 years, and that's pre-pandemic. And to be fair, when they say administrative burden, what they're talking about is things like prior authorizations or L&I saying that here are the 2 forms that you have to fill out at every visit if you want to get paid for the total episode. I had a colleague once speculate that there was a whole bunch of people who got their satisfaction from telling physicians what they had to do. The nature of medical practice is changing. Thank you. 25 years ago, most physicians were self-employed. I took it over from Don Solberg. Don Solberg moved here and practiced in this community for 37 years and built a practice. When folks of that generation graduated, they graduated without debt, but without money. And they built their practices with sweat equity. They also were the identified face of the practice. Now, over 90% of physicians are employed. The practice is a job. And like any employee, they can change jobs every few years. They don't have to run and grow the business. They also have some increased frustration because as employees, they didn't have the autonomy that that their mentors had as proprietors. And today, medicine really is a team sport. Especially with the physician shortage, we're more reliant on our PAs and our nurse practitioners to extend the reach of the physician. Patients find that frustrating, but it is part of the realities of 21st century medicine is that you're going to be cared for by a team. And that team won't just include a medical provider. It can include a social worker. It can include a behavioral health consultant. And it's a shift in provider expectations and a shift in patient expectations. So with that shift, where did the private practices go? What happened in this county was they came to KVH and said, I'm about ready to retire. I would like you to buy my practice. KVH never went to a provider and said, we want to take you over and run your business. It was the providers that came to us and said, help us out. The last thing I want to call out on the changing nature of practice is the changing nature of training. Most medical training, most residency training takes place in urban centers. And in the urban center, you might have a program that has an ambulatory focus or one that has an inpatient focus, but rarely both. For instance, the University of Washington has 2 programs that lead to the degree of Doctor of Pediatric Nursing Practice. One of them is entirely ambulatory, one of them is entirely NICU based, so that those graduates really aren't able to both see patients in the clinic and when needed, see patients in the hospital. To further complicate things, just this year, ACGME, the organization that sets the rules for graduate medical education, put a new work hour restriction in place that if a resident is given an assignment where they have to be available for overnight calls, so they're working 24 hours straight, they cannot work for the next 8 hours. So when I was in training, if we were on call one night, we did what we had to do, and then we were in clinic the next day. You can't do that anymore. We've looked at what that means in particular for pediatrics. And do we look at having a dedicated workforce that just takes care of inpatients? We don't have the volume to sustain that. So we have to come up with some way to support our ambulatory providers in the hospital.
Dr. Martin, is it all right if I ask a question?
Sure.
So what has motivated this move from self-employed to employed physicians? Is it primarily the regulatory burden?
No, it's economics.
Okay.
If I'm self-employed, I capture the revenue for what takes place in my office. But if I have to send somebody out for a CAT scan or for unusual lab work or more than basic imaging, that money goes somewhere else. In a system like ours, we can actually capture that and use that so that you see month after month that clinics lose money, which is part of the story. They generate money elsewhere that isn't directly attributed to them. That delta, the difference between what's directly attributed and what they actually realize, allows a system to pay them more than their direct revenue. When I moved from being a partner to being an employed physician, my income went up by 40%. And in private practice, there just wasn't the workflow or the revenue stream to pay what an employer could pay me.
Thank you.
Next slide. So, given that I've been looking at practice transformation and these increasing burdens for over 15 years, what have we done to lighten the load? We've known there were problems. We've looked at dictation solutions to reduce the documentation burden. You guys have heard about Dragon. We've used Dragon Medical One. We're looking at Dragon Augmented Experience, which is a cloud-based AI that hopes to produce fairly complete notes by the conclusion of the visit. We've also used remote scribes such as Augmetics, which when I worked with Augmetics, it was literally the first time going back to the days of paper and dictaphone that all of my charting was done at the end of the day. We've worked to develop care teams that support the providers. Most recently, you've heard about our pharmacy tech programs where we're using farm techs to handle refills that don't need a physician's input. We've also looked at referral management so that a lot of the prior authorization work doesn't land on the physician. We've examined innovative scheduling models, recognizing that once upon a time, every hour of patient-facing time generated 90 minutes of work. Then it was 2 hours of work, and today it's 2.5 to 3 hours. So we have to look at how many patients we're scheduling if we want people to be able to return phone calls, deal with labs, and so on. Dr. Hibbs has been working on a physician consultant model where the physician, rather than seeing routine patients, would be seeing complex patients, but have increased availability to support APCs. And that really is one of the more robust ways of thinking about a care team. Most appointments would be with an APC, but many appointments would have a physician pop in and ask additional questions and really help the patient see the reality of who all is involved in the care. Another thing that we've done just to try to bring fulfillment to the job, recognizing that many providers, regardless of their level of training, love to teach and find that rewarding and fulfilling. To the extent that it's rewarding and fulfilling, it makes the day seem shorter, it makes the work seem lighter. And that's one of the reasons that we've worked to create an academic calendar in partnership with all 3 medical schools. and supported our local residency. Next. So every month, the first part of the report you get from me talks about recruiting. And usually it's just a fairly dry assortment of numbers. We interviewed 6, we made 2 offers. So-and-so is starting. I want to pull the curtain back a little bit. What we do to get those people in here, we're working both with outreach through professional organizations and to the schools, as well as partnering with several different recruiting agencies to bring people here. One of the mistakes that we made in recruiting early in the pandemic was we were really fascinated with this Zoom stuff. And we used it for the first interview. And what we found was that if we didn't bring people here, if they didn't see Ellensburg, if they didn't walk through KVH, then we were just a dot on a map. And they were picking us because we were close to Seattle, and it wasn't hard to find other opportunities that were closer to Seattle or closer to Vancouver. We tried some fairly aggressive marketing campaigns trying to increase the awareness of what the difference is between a commute in Issaquah or Bellevue and a commute in Kittitas County, and what your life looks like after work here versus on the other side. One of the things that we've done essentially continuously is study the market and make sure that our offers are competitive. What we hear is that we aren't losing applicants for the most part based on pay. There have been a couple of outliers, and frankly, at least one of them I don't think was being entirely honest in what he was reporting. The offer that he described, if he got it, good on him. There's no way anybody else was going to match it. We know that we have to be competitive if we're going to get talent here. One of the things that our recruiting partners tell us continuously is that our benefits and our retirement plan in particular are very, very generous and are a real draw. And Maddie, you want to talk a little more about the employee referral program?
Yeah, we started an employee referral program to really highlight hot jobs. And with hot jobs, if an employee refers somebody for hot jobs, which the majority of our provider positions are considered hot jobs, which are hard to fill. They've been open, and there's certain criteria, but been open a certain amount of time. Just critical openings we have multiple openings for. Our employees can actually get compensated for that at the 90-day mark and 1-year mark if that provider or employee stays with the organization. So that's been an exciting thing. We have had people take advantage of that for provider positions. So really starting to help people understand what we have opening, what our needs are, refer their friends, and start that program as well. I'll also add to, in terms of studying the market and ensuring that we're competitive, between medical staff services and HR, we did join a professional network of physician compensation professionals. So that there is a professional network of that. Jason, who's on the line, actually went to the conference this past year. And so we've been able to really kind of partner with other healthcare organizations and kind of test things out and make sure that we are being competitive and using best practices in terms of incentives, rewards, and compensation. So that's been an exciting opportunity for us to learn more as well.
And Jason went to that conference with Dr. Thomas.
Yes, yeah, that's right. Great.
One of the things that I think, as an aside, we're really trying to increase the awareness amongst our providers of what we're doing and what's involved and what we can and can't do.
Yeah, I would just say in terms of benefits, we recently took a look at, I think we provide $90,000 in student loan repayment for physicians and our APC. So when we talk about benefits, that if we relocate them, there are sign-on bonuses associated with it. There's student loan repayment in addition to basic compensation. And then our compensation model includes rewards for production, for quality, for patient satisfaction as well.
And we'll come back to those incentives in just a moment. So one of the things we did, and this was really driven by feedback that we got from our emergency providers, was we have expanded the access to benefits amongst our staff across the organization as much as we can. And Amanda, that's really more your bailiwick in terms of the FTE.
Yeah, I think we had a lot of good conversations around some of our provider structure of the emergency department.
But
Included is not always at 1.0 exact FTE, and we had this complicated benefit structure that broke it down by the 0.5, so 0.85, 0.9, 0.95, all got a different rate of benefits. We changed that over the past year so that more part-time providers had access to full-time equivalent benefits, and that I think was really well received. That way, their benefits were fully provided for the medical and at that lower rate, which was great. Looking at other.
additionally,
Go ahead. Sorry, Dr. Martin.
that's okay. I was just moving to the next bullet. We recognize that we can't spend a ton of money recruiting without recognizing the work of the people have done here. This board has twice approved retention incentives for staff for what they've done for the organization and for the community during the pandemic. Additionally, our compensation manual now has structured retention incentives as well. And this really is something I think Amanda gets a ton of credit for, is investing in staff and providers' career development, really trying to expand our physician leadership and the investment that our staff feel in the organization. And you've heard about the success of the MA development coordinator position and what that's meant in terms of retention. I'm going to hurt my shoulder patting us on the back on that one. Amanda?
Yeah, we've had a lot of great involvement. You know, Team Steps, for example, we've talked a lot about the Team Steps program for safety communication organizationally. We had provider representation. Dr. Thomas said she was able to participate in that as well, and really look at team-based communication development. So that's been really wonderful. Dr. Martin and I have been partnering, and which is great that we're doing this presentation together, regularly now, meeting to align, to make sure all of our workforce strategies are aligned and kind of meeting our vision and goals and plans. It doesn't mean that they have to all be the same, that what we offer providers is always equal to the same opportunities as our staff, because sometimes there are unique needs and requests, but to make sure that they're all aligned and that we're looking at the provider experience in relationship to overall staff experience as well. We also have kind of another meeting that we do about physician engagement specifically. So monthly, Dr. Martin and Michelle and Dr. Hibbs and I meet to talk about any physician feedback we're getting, physician engagement survey, recognition activities. We also started a lead provider education program. And so we've been doing those quarterly. We'd like to do them quarterly. Sometimes scheduling takes a little challenge, but we've had several speakers external speakers, and sometimes we talk internally about our strategic plan over a breakfast. And so we've been really excited to increase communication with our providers that way. And we've gotten really good feedback and had some really good conversations through that. And just kind of moving along to some of the other workforce strategies we talked about. So the wellness activities, we do have provider representation there as well. Dr. Meryl Stesko is really engaged with the wellness committee and just doing a ton of great work and great perspective. And the wellness committee, as you know, is doing everything from art classes to garage studio fitness memberships to volleyball teams, healthy food in the MAC. That was a big conversation for
Softball's right around.
Softball. So just tons of great work. We invested in the Headspace app for our staff, and now their families actually have access to it for meditation and mindfulness resources. So just shout out to Dr. Meryl Stesko. He's been a wonderful resource there, but that's kind of, again, an example of where we want to align all of our opportunities together. The networking outside of work, I think that goes back to some of those activities that we plan. And again, we all get together now regularly to listen and look at what we're hearing, so that we can take action and make sure that we're listening to the feedback of our providers and our staff.
Well, and Yeah, those last three in particular, well, actually 4 of the 5 that you've heard so far, were not great ideas that we came up with in a vacuum. It was something that somebody suggested and we heard it and we said, okay, that sounds like a really great idea. Why haven't we been doing that? And so we started doing it. And I wish we were this creative. So the most obvious thing that we have to do to retain is make sure that we stay competitive with market. This is just looking at what our average compensation for physicians and APCs. It says MD, it should say MDDO, my mistake. But what that's done over the last 6 years. It's interesting because fundamentally the way that we've compensated has shifted in primary care. The base pay has gone up, but not to this degree. This really is the result of the work that started with the Values Alignment Committee, and Bob and Matt, you were involved in that, and trying to say, okay, what's best for the provider, what's best for the patient, what's best for the organization. Let me rephrase that. What's best for the patient, what's best for the provider, what's best for the organization. And trying to make sure that people were getting incentivized for doing the things that mattered to patients, like getting them seen. And I think a lot of our providers have seen increases. We had one provider that we offered a contract to that had a very generous base salary. He rejected the contract in favor of something with a lower base, but more of an access incentive. And he's doing quite well on that contract. And that's outside of primary care. So we have had turnover. On the provider side, the number one reason when we talk to people on their way out has been personal. I've got a relationship on Whidbey Island or Mercer Island, or my partner got a job in Eugene, or Ellensburg isn't the right place for me right now. That's probably a third of the turnover that we've had in the last 5 years. Number 2 is retirement. When I came to this community, we had a very generational workforce, and most of them were at the end of their work life. And that's another quarter. There have been some providers who have been terminated, and the board has been kept apprised of that. It's something that is done respectfully. It's done when a provider isn't able to meet our values. Most typically, it's respect for the coworkers. And we work with them, we coach them, we go through multiple steps. But at some point, if it comes down to this is the behavior we need and you aren't able to do it, then we need to go our separate ways.
Yeah.
Other staff?
Yeah, and other staff, so we do have exit interview data that we've started doing the past few years. So relocation is our number one reason, pay and compensation. And again, we've all talked about that, the changing, especially during COVID times with some people, nursing, there's very competitive pay in terms of traveling agencies and some of those agencies, but also just sign-on bonuses, and people are being aggressive. And there's a lot of shuffle in the workforce in many organizations during that time because the opportunities were there for people if they did want to leave to pursue better options. And personal reasons, so that could be other things as well. In terms of exit interviews, we've had increased data now on the other staff side, so we're able to pull that directly from our data. We are working to better have a process for the provider side. So Dr. Martin does have, again, he's referenced, he has good relationships, verbally shared these reasons with us, but we are looking to tighten up to have more of a formal process with exit interviews with providers. Some of it is just a logistical thing with information flow. By the time that the official resignation letter gets processed through HR, they're already gone and things like that. So we're going to be working to in our teams to increase that as well. But we do have some great feedback from people. We have done exit interviews, but we'd like to make sure that we can capture more people as they're leaving. And we've already started that process, looking at some of those folks that we know their dates are coming up in advance to be able to contact them and get feedback. So, they may be retiring. They have other feedback that they'd share about their experience that would be helpful for us that may, relate to some of these other categories.
Amanda?
Yeah.
Do we do any ongoing check-ins with providers like on an annual basis? The same sort of discussion you have with an exit meeting, but just a middle of the career or, is there anything we should know now that is maybe pushing them in a direction to get them thinking about, I need to change? Do we do anything midstream?
In terms of individual interviews, not currently, but I think you bring up a good point. We have, the Values Alignment Committee, for example, the Physician Lead Breakfast. We're trying to create opportunities where we can have more interchange of communication and not more of a group level. But I do think it's, what in the industries people call stay interviews, kind of their retention interviews, basically. And I think it brings up a good point that we can certainly talk about in our physician engagement committee and start talking about is how do we get the feedback before they're already leaving and walking? That's always the challenge. By the time we sit down and talk with them, there has been times at the staff and provider level where I'm like, well, gosh, sometimes people leave on a misunderstanding that maybe it's a misunderstanding of their pay or benefits that if we actually would have known, being able to sit down with them ahead of time, we could have explained to them some of the things that are in the works or things that are coming that might impact them or help them make a different decision. So yeah, great point. So
Can we back up one slide?
yeah.
So I'm assuming this chart does not capture locums or travel.
No, this would just, is that right, Dr. Martin? This is our employed providers.
This is employed providers through 2022.
It would be interesting to do another chart overlay that includes locums and travelers. I'd like to.
We would
see
be
how
better
that-
off doing,
Go ahead.
we'd be better off doing that on a log scale.
Which might be very informative.
Yeah.
The gist of my point, which I don't want to belabor, is if we're willing to pay that money to people who have not committed here long-term, is there anything we should look at to take some of that money and make these lines of people committed to Ellensburg a little higher? And would that do us any good? But again, it's a very long discussion. It's not meant for a meeting like this, but it's the sort of thing I would be curious about, be willing to spend time with anybody who has access to those numbers to brainstorm this sort of thing.
How could you pay locum less? And they,
No, that's my point though. But if by adding a certain amount to the people we're trying to hire to get them to pick us over another choice, I know there's a lot more than just money, but if we're willing to spend $2 million on a locum for a couple of years for something, what if we just made the salary of somebody committing here long-term? That's my point.
And that's
down.
And that's actually the thinking that went into putting retention bonuses into our compensation manual. It doesn't get people to locums money, but quite frankly, one of the things that we're starting to see in the market is folks are getting tired of traveling. And we're seeing this really in nursing right now where the travelers workforce is shrinking and people are coming back to work kind of like we thought they would. So it is an excellent conversation. I think we've started trying to do some of that. How much more we could do, because on the one hand, you're right. I would rather give that money to the people who are committed here. The justification for paying locums is to keep a program open until you can get somebody in place. But the money that we pay them, frankly, isn't sustainable.
And I don't want to minimize the gap because there is, private companies, they in a public hospital are totally different, I guess, financial packages. But part of it is that's very interesting because this has come up on the nursing side too. We have a lot of travelers, and labor costs is a different category than individual compensation. But is the impact of the benefits? Because I know that we looked at some of the costs for our international nursing contract and we're like, oh, the number scared us. But once we actually started doing the math and said, well, wait a minute, we've been paying this much in benefits and this much in retirement, the gap wasn't as big as it sounded. So we have looked at that, but there is still a gap. I mean, again, our market, we do, as Dr. Martin said, do a lot of analysis with our market and compensation surveys and data. And it is just a market that we look at than private companies that have access to the locum. So, but yeah, great point. And I'd be happy to talk anytime about that.
And I'll apologize to the board. We were asked to do a 20-minute presentation and you've got us wound up. So I'm going to try to blast through these last 4 slides. One of the things that's contributed to turnover is when we have changed the model of care. So when we went to a partnership with RPG for hospital medicine, that contributed to the number of physicians on staff, but not employed by KVH. But those who had been employed as hospitalists, we didn't have a program for them anymore. We have collaborated with Emergency Associates of Yakima. That one I went into expressly with the idea of protecting the FTE of the providers who had been with us through all of COVID. And we've been able to do that. And that partnership is off to an absolutely stellar start. As you know, we're partnering with Evergreen Anesthesia, and they will be providing call services in the very near future and supporting our Kittitas Anesthesia Associates. And we will transition from Kittitas Anesthesia to Evergreen Anesthesia by September. Amanda, you want to speak briefly about our other staffing partnerships?
The health carousel is that international nursing contract we talked about, which we do have our first hire, which is really exciting. We're still working through the process. Augmetics is the scribe delivery system that Dr. Martin referred to, and then of course security. That was something that over the last few years again came from feedback from staff and just looking at ways to protect our staff, and with flow for COVID, flow to our hospital as well, and then OnRad, of course, in radiology we talked a lot about. And then Dr. Martin, if you want to talk a little bit about the industry changes, again, with different models of who's treating inside and in the clinics.
Sure. So once upon a time, for example, and I kind of alluded to this when I was talking about the inadequacy of current training models to give us the workforce we need. In rural medicine, we need the obstetricians and the family physicians that will see patients in the clinic and come into the hospital when needed. And same thing with pediatricians. That is not the way that most of the world is working today. Most places have laborists, so that you spend your pregnancy, a woman spends her pregnancy developing a relationship with a provider who isn't there when she delivers. I think that these are models that make great sense economically and for the lifestyle of the provider, but really tragically discount the value of the relationship in the care process. But it is real, and it is the expectation of the people that are training now that, what do you mean that I'm going to have a clinic schedule and be in the hospital? That if I have to go to the hospital for a delivery, that's disruptive to the clinic schedule. If you're of my age, you say, well, yes, it is. But that's what you have staff for. But that's not the industry today. So with all of this about how hard it is to get folks, how hard it is to keep folks, how are we doing? We have had high turnover. If not silver, at least bright gray lining is that we've been able to more than keep up with the losses. That said, we'd be in a lot better shape if we didn't have the losses we have. And trying to understand how we can impact that is the work that my team is engaged in. And Amanda, do you want to say anything about the clinic side, nurses and MAs?
Yeah, well, I think, we've talked about a couple of things already in terms of MA development. That was a huge focus. We have our MA development coordinator, which has been huge, our MA apprenticeship program, which has been huge. a lot of efforts there, and we want to support the whole care team because it's disruptive for the whole team if there's a lot of shuffle and turnover. But I do want to point out that, just looking at this was very interesting putting it together, but we're on track for maybe, if you annualize, we're halfway through the year, probably about 3 to 5% if we keep at the current rate with MAs, which is we're really excited about. So kudos to the clinics and all the hard work you guys are doing. In previous years, and this is a hot job for all healthcare organizations, is the MA, but we were even up to 48% in some areas, which we're very happy to make a lot of progress there. You see the same with the clinic nurses. We've done a lot to increase compensation and look at structure. We have a new nursing director of clinics, Jamie, who I got to meet for the first time today, who's great. So a lot of efforts there. So kudos to the clinics for those areas. I do want to point out, though, that the year-to-date turnover for on the MD side, that's not one you really annualize. So don't panic that when you add that up and times it by 2, we're not looking at 40% turnover for the end of the year. With providers, we in most cases, unless it's unexpected for any reason, we have longer notice periods. So there's a 90-day period in the contract, or sometimes we're retiring, they give us 1 or 2 years. So that's not one we're surprised by that you annualize the data. That's for the people who are retiring this year or that we do have expected turnover. I think Dr. Martin's engaged in those conversations already. It's not a surprise to us. We know those, but again, anybody can make a decision at any time. And because of that long period, that window in the contracts, the people who actually have turnover in 2023, they probably gave notice in 2022. So that's why the data.
In the case of Jose Diaz, he gave his notice in 2021.
Yeah, exactly. So that's why it's a little hard to look at percentages with the providers. So I just want to add that there's a little bit of nuances there. And if we do some of those global program changes that Dr. Martin's referring to, the hospitalists with RPG, security, that counts in that turnover number when we pull it from our system. But again, it's a model change that those people might still be with us. They're just not getting a paycheck from us. They're not employed with us. They still show up in these numbers. But either way, it's more than we want it to be. So we're working really hard to decrease that. So anything else you'd say on that, Dr. Martin?
Yeah, Dr. Larson's a great example of that, who went from primary care to public health and is still in the building, still working as a hospitalist, but he's not our employee at this point. He's just a member of the family.
Do we have access to the data for other similar sized hospitals, rural hospitals, the sort of turnover that they're experiencing?
Yeah.
How do we balance out there?
Yeah, we do. I will say in the HR collaborative, in the past, there's been a much more effort on the rural hospitals meet all together and share some of that feedback regularly. They had more of a metrics report for that I haven't seen in a while. But I think it's because it's been so unpredictable. I mean, people have just been it's been such a gap everywhere that I think it's been, the conversation is, how is everyone surviving? Because it's such a challenge. We haven't really staged a lot of big statistics and so good point in comparison. But in healthcare for overall workforce, I've seen it ranging by year between 20 to 25%. That's looking at an overall healthcare workforce. When you look at some of these jobs, there's such a difference that is so powerful that when you loop all the job titles together, it just doesn't really paint the same picture. I mean, nurses are going to have different needs than providers and MAs. We hear different things. So some of that overall turnover of being in the 20%, it's a nice benchmark to look at, but we know that there's a lot more specific information that is needed to really understand it. So
I don't know if you get to this in a coming slide here, but one of the things to note is that, it's all right, maybe you're getting at it.
no, I don't know yet, but
that there has been a net increase of providers, and what we're trying to do is to keep up with the demand, and especially with increased service lines, new service lines. So one of the things to note is, yes. So is that the next slide? Okay, good. Thank you. I'll be quiet and let you guys talk about it.
So why are we talking about this? We're talking about this because we're trying to protect access. We're trying to make sure that we've got a stable workforce and we're meeting the needs of the community. So if you look at how many primary care visits we did in 2019, we did about 66,000. Last year, we did 88,000. This year, based on numbers through May, we're on track for almost 100,000. So between working smarter and the modest gains that we've made in the workforce, we're going to provide just about a 50% increase in the number of visits over the last 4 years. To me, that now some of that, there is an artifact in that because the pediatrics clinic wasn't contributing to our numbers 4 years ago, but they account for a third of the gain. We're still looking at a huge increase year over year. So does that get to your question, Matt?
Yes. Yeah, I mean, it's just in 4 years, a 50% increase in the number of visits. I mean, what it tells me is that that we have all these sort of national forces, national trends that we're sort of struggling against, but we're managing, or we're doing that well enough anyway that we can handle a 50% increase in patient visits. So it's not like we're reducing care; we're actually increasing care quite significantly. Anyway, yeah.
The other thing that we haven't called out explicitly, but just in terms of access, is 7 years ago, none of our clinics were taking new patients. They were all maxed out. They couldn't expand. And largely as a result of the board's emphasis on access, we figured we didn't have the luxury of having closed clinics. And it worked. Bottom line.
Anything else?
One more slide. Like Matt said, there are challenges that are beyond our control, systemically, globally, economically. That said, it is our problem. And we have to figure out a way to mitigate. We have to figure out a way to adapt. And we have to do it better than the folks down the road if we want to compete for good talent, for passionate providers. We've had some amazing interviews in the last 2 weeks. So we're doing better than a lot of folks are. But we are looking at this and know that we can do better, and we have to try to do better.
Dr. Martin, just to put a fine point on that first bullet point there, can you please just repeat currently the number of primary care providers that were down nationally? What's that number again?
30 to 50,000.
30 to 50,000. Yep.
And we graduate about 3,000 family doctors a year. It's harder to know how many internists and pediatricians to count because they tend to subspecialize after they finish residency. The number of general internists is shrinking. Another challenge that I didn't call out explicitly, but it's one that we're working to deal with organizationally, not necessarily from a workforce standpoint.
Okay. That was a really, that was a lot of really good information. I appreciate the presentation. Would you guys mind sharing that PowerPoint with the board, please, so that I know that this is something that's really on our minds. Are there any questions about the presentation as we sort of close it up? Questions from the board?
That was a really good dive.
I wonder if we need to hire like an agent out of Los Angeles, because Hollywood's kind of slow right now with the strike. But somebody who's a really good closer, and when you find a provider that you're excited about, this person spends a day or two with them at their home territory, whining and dining, and just closing the deal to bring it home. So, but yeah, like Matt said, we really appreciate the presentation. It's very informative. We appreciate the enormous struggles you're facing to solve an equation that may not have a simple or answer as it stands, but keep being creative.
Well, when did we start having someone whose primary job was physician recruitment?
2016. That was my first board meeting, you approved the position.
Has it been? I always forget to delete or add the COVID years into the mix, so it's 4 years, it's actually 7.
We created that position within about 45 days.
Other questions from the board? All right, thank you very much, Dr. Martin and Amanda.
Thank you.
Thank you.
Travel safely.
Okay, well, that was a rich presentation, a lot to think about. Next up, we have public comments and announcements. Remember, if you have a public comment, please state your name, your address, and try to keep your comment to about 3 minutes. Remember that we do not respond to public comments in the meeting itself. But we are happy to hear comments from anyone who's here. Is there anyone who would like to make a public comment or announcement right now?
I will. I'm Nancy Weeking. I've lived here 41 years. Our daughter is a neonatal nurse practitioner. Our son is a health and safety supervisor. And so, you know, we're definitely into health, although my husband and I are education. We're both 80. Our friends are getting to be that age. So I've addressed Peterson, and she wrote me right back, you know, this is a small town, people talk. So when I hear 22 people, providers have either left or are leaving, I get a little nervous. And I've been told that by nurses, by PAs, you know, internally, I've been told that, not just rumor. So my two concerns are, this is a wonderful presentation. It really helped me understand things of the struggle in our small county. My one concern is the lack of retention, I guess I'll say, is hitting my family because my lovely nurse practitioner at internal medicine, I've started with her, really liked her. She said, oh, I'm sorry, I'm leaving in August. My husband's PA at ortho said, oh, I'm sorry, I'm leaving in June. My grandson's pediatrician, my daughter said, a guy who we really liked, he didn't want to go to a woman, you know, he's 15. He's leaving. So, I mean, it's kind of come down on us as a family. So I'm glad, you know, looks like things are getting better, I guess. And I don't know who I'm going to now. I don't know who I'm going to go to. But I'm also concerned about healthcare for the aging population because I am one. So, you know, that needs to be addressed, I think. We are aging. We have a lot of people moving here. Oh, why are you moving? Oh, my daughter's here. You know, that kind of thing. So we do have a large population, I think, that needs to be addressed. But anyway, we've lived here 40 years, stayed with KVH, loved our Dr. Carr, loved her, Dr. Wendy Owens, she left. Dr. Breeden went to community health, forensics. And then, you know, I started and now I'm lost without a provider. But anyway, I'll find somebody, but we've been very happy, have not had too much major done here except colonoscopies and knee replacement. Our back surgeries have been in Seattle, of course. So anyway, I appreciate this very much and I'm glad I came and I will spread the word to a lot of people who are talking to me, and we do talk. What are we going to do? Who's our provider? You know, we've lost them. What do we do? So I appreciate coming, especially for this presentation. Thank you.
Thank you very much, Nancy. And just for the public record, so we have it, would you mind spelling your last name, please?
No, I mean, yes. W-I-E-K-I-N-G. King. Yeah.
Thank you very much. Appreciate your comments.
Yeah. I'd like to
Any
make
other
a
pub-
personal,
Yes, sorry. Go ahead, Dr. Brown.
Kevin Martin, resident of Ellensburg. I just want to take a moment of personal privilege. I was reflecting earlier this week on a comment that Matt made in the height of COVID when we were working on the regional triage team committee, and Matt made the observation, you guys are trained for this. I'm not supposed to be doing anything practical. And I was talking with a colleague from that group earlier this week, and she was sharing some of what she went through. And I just want to say thank you, Matt, because you're right. You stepped in and did work that you never thought you'd be asked to do. And at a very personal level, I appreciate that. Thank you.
Well, thanks, Dr. Martin. I really enjoy working with you and the rest of the committee. It's very enriching. Other public comments or announcements? Okay, thank you very much. Next up then, we'll start the reports. First up is quality, Mandy Olson.
Let's start on page 12. So the first thing in my report is about our DMV survey and corrective action plan. I did just get notification today, and I haven't even got to tell the whole team that our corrective action plan was accepted today with no clarifications, and just a week after submitting it, which I was thrilled about. They said it could take up to 4 weeks for them to review and accept it. And we have in the past needed clarification. So I'm just really proud of the team and the work they did to get that corrective action plan. It's very thorough, and I think people are really excited about the work we're going to do.
Are there any challenges on that plan, or do you feel just follow that plan and we'll cross the finish line getting these things?
There's a few things where I think Ron's got some issues where we're going to need to use a contractor. And so it might be challenging with timeframe and materials and workforce. There's a couple there too, where Ron's team is having to work with space issues. Like, so the CCU med room, there's some real challenges with this.
Lack of space?
The space in that room, yes. And it's about splash guards and sinks, and how are we going to make that work where people have the supplies they need, but we're maintaining the infection control. Hand hygiene is going to be a team sport, like Anna contributed here in that, but it's work we're excited to do, and it's I don't know, it's fun to work in person as a team together. I don't know if anyone else has any things they think are going to be really challenging. It all seemed like work. Yeah,
So in the near future, I've asked Mandy to come and address with the board sort of this DMV is a journey, and there's a ISO 9002. Is that
what 9001?
9001 learning curve that we all need to be on. And so in addition to just passing the survey, there's this entire sort of view that we need to change about how we look at processes. And we've had some people go to some training over in Morton, I think it was, at Harvard Health, but there will be a lot more of that. And I think as we look at their expectations for our quality, you've heard us sort of struggle with what they're asking us to do with our board quality improvement committee. I think that's because we're just at the beginning of this ISO 9001 project. So it's bigger than just an annual survey. It really is sort of the lens you put on your organization.
And that's one of the reasons people choose DMV, is that they do use ISO 9001. ISO 9001 is for everyone. It's for any industry. It's a quality management system to help improve any business. And so some of what's difficult is understanding, how does that framework work for us? What changes do we need to make that are more structural changes? And what is it that we do already that actually fits this model? And so that's what we're trying to sort through, right? Like, what do we already have in place that we don't want to disrupt and is working really well and meets ISO? And what are things that are kind of completely different ways of thinking that we do need to change. So they do say this is our year 1 survey. Next year, our survey is year 2, which is they call kind of a dress rehearsal for ISO certification or that we're compliant with 9001. And we get to decide whether we're going to go for certification or compliance at the year 3 survey, which would be our 4th survey with them. Our
Which is higher
recertification.
ranking.
You get more, one costs money, but you get reporting from them. It's just, they have a different badge that you can put along with your name that says you're ISO certified versus ISO compliant. But their feedback to you is a lot greater if you're certified. So they give you more extensive reports about your areas of opportunity, even if it's not a nonconformity or where you're doing really well. So you get a lot more feedback if you choose to be certified.
One of the things from the frontline piece that I think is different between being surveyed by the state versus the DMV is that the state is not very helpful when they find something. So they will not provide guidance or any kind of education as to try to manage whatever it is that they find. Whereas DMV is very helpful. They want to help you be where you need to be. And their interaction is more like an educational piece, not a slap on the wrist. It's more like, how can we help you get where you need to be? And they provide direction and guidance, whereas the state would just come in and say, well, you did this wrong and figure it out. So I think that's one of the benefits of DMV is that they're very approachable and they want to help us get where we want to be.
So we have some education coming up this summer. We had planned education with DMV to provide restraints training to our ER nursing staff and MedSurg CCU nursing staff, and that's coming in August. And then we'll also have some KVH specific training that's kind of related to this survey coming up this summer as well. Any other questions about DMV? And then, other than that, I don't have any updates. I'll take any questions if you have.
Is the board all aware that Linda Navarre is retiring? So we
Yeah.
are taking this opportunity to look at that position and we'll probably move some of the quality and risk work around. I'm
Big
not-
shoes to fill.
Yeah, I'm not sure we can run a hospital without Linda Navarre, but we'll find out.
Yeah, I mean, Julie was talking about, this is, I'm thinking risk management, I'm used to it this way. And I'm like, this is the only risk manager KVH has had. So Rhonda created the position when she stepped into this, role years ago. And so it is going to be huge shoes to fill, but it is an opportunity too, to look at where can we take more of an enterprise approach to risk management or separating some of the risk and quality activities, and that be a benefit for us. So I'm really set. She's set to go, but she's hoping she'll get to volunteer at KVH at some point. Maybe she can be our, on our patient family advisory committee. Yeah.
Any other questions for Mandy about the report before we look at the dashboard?
Just that patient story is really, really fantastic. That was delightful to read and just for the impact she made on this family.
They do. Every letter we get goes to the employee directly and gets put in. If it's related to a physician, it goes in their physician file too. So they do get to hear about they were how.
Any other questions about the report before we look at the dashboard? Okay, so you guys hopefully had a chance to review the dashboard before today. Mandy, is there anything you want to call our attention to on the dashboard?
Just the fall risk strain. So on page 1 in the bottom left corner, those are our clinic measures that they have been working on for a little over a year now. It was really hard to get this data in a way that we could share with the teams. But really great work by internal medicine and FMCE. They're above the goal for the fall risk screening. And for the first time, someone is at goal with the diabetic quick checks. Internal medicine hit that. And it's all moving in the right direction. And next month we'll have even better data. Sorry. So I'm excited about that. But they've all been working really hard. Tony Clayton goes and to all the clinics and shares that data with them. Especially Dr. Thomas and Stephanie up in Cleellum have been doing some really neat work with how they identify patients. They're doing a great job. Just the compliance concerns in the hospice length of stay data is not new. So it's the same, it's quarterly data. So there's nothing new there.
Anybody who has a question or wants to talk about something specific in the dashboard? Okay, well, we appreciate it, Mandy. Thank you very much. Okay, next up then, we have our CEO.
So the big news is that we have received the preliminary results of our survey of patient safety. You'll recall we had an 82% return on that survey. So I've been rolling around on that data all day, and my office is covered with sticky notes, and it's fascinating, and there is some really exciting work, and it's all very there's just some messages that it's like, wow, that is going to be really good, exciting work to do. And I really appreciate Mandy encouraging us to do both a hospital survey and a clinic survey. Very different messages, very different opportunities in those two settings. And again, I'm ready to get started on Monday. So somebody's going to have to take my foot off the gas, because it's great data, and it's what you get when 82% of your employees participate. So really looking forward to that. I am not an easy person to intimidate, but we had a meeting, Cody Staub called this meeting earlier this week, and we had Dr. Sam Arbabi, who is the head of trauma at Harborview Medical Center, come and visit us with his team. And I was like the head of, yes, that's it. And he was here to talk about our transfer data, to talk about our relationship with Harborview. We had an opportunity to talk up KVH and talk about, our sort of ownership of this market, our county. But it was really impressive. They came to say, how can we support you? What can you do? What can we do for you? How can we keep more care local? So the meeting, Dr. Martin was in the meeting, I think, Cody, Mandy, and myself. And we are just so fortunate to have a resource like Harborview. And, throughout the pandemic with their WMCC helping with transfers, that what an outreach from a world-class organization like that to come see KVH and say, what can we do? So again, I'm generally not intimidated, but I was in that case. So I want to call out some work that Tricia is doing with Orrin up in Cleellum with the Integrated Behavioral Health Program. You will be hearing more about that in the context of budget. Orrin has done a very good job launching that AIMS model program up in Cleellum, which I think you're aware they transferred that learning down to Family Medicine Ellensburg, which they outgrew, I think, in the first 30 days of the program. We're hearing now from pediatrics and women's health, they want many of those same resources. So Orrin and Tricia are kind of looking at how to stretch that behavioral health, support the social workers, the psychiatric nurse practitioners, more of our primary care base. So that's on the way. The other thing I will just mention, last week we were privy to communication from Multicare. Multicare is budgeting a loss by the end of this month. So for the first 6 months of 2023 of $156 million, that's going to translate into some very steep cuts in hopefully not clinical care, but Yakima and the Multicare facilities have already experienced cuts. So we're kind of standing by to see what that's going to mean to us. when I heard that, I went out and looked at the other reporting that's been done for 2022. Providence, including the Providence hospitals, the Swedish hospitals, and Catholic in Richland, who are all under the Providence umbrella, posted a $660 million loss for 2022. So we are, as a system of healthcare in this state, we're going to see those impacts. No one is projecting that Peace Health or any of the other large systems did any better. So I am happy to answer any questions.
Since you mentioned the retreat we had 3 weeks ago, I'll just take this opportunity and repeat something that I said at the retreat. I speak for the whole board and saying that we appreciate how productive these conversations are about the strategic plan and how it actually does inform kind of on the ground activities at the organization. I know that this doesn't happen at every organization. Sometimes strategic plan is sort of a nice thing for a pamphlet, but to see it to show up in the CLOPI plan and to see it actually have an impact on the whole organization, I know it's very it leads to very fulfilling work for me and the rest of the board. So just I just want to express our appreciation for how seriously you take that process and you know the fact that as a board it feels like we're doing something that actually impacts the organization. So anyway, thank you very much for that. Any questions or comments about Julie's report?
Are there any big takeaways from the future of OB meeting that was held? Or are those still, marinating?
It was very, very well attended. I asked John to attend that meeting, and I know Dr. Dawson, and she was the one that asked for that meeting. We had pediatrics, OB, family medicine. John was there. Stacy Bonton was there. Who am I missing? Who am I a family? It was a very rich conversation with some, for me at least, Dr. Martin, Dr. Hibbs. Mandy facilitated. Thank you very much for that.
Michelle.
What's that?
Michelle Worrell helped a lot too.
We came away with pages and pages of notes, but I think it confirmed for me that the future of supporting OB is in family medicine. That is the only place that we have the number of people that we need to support our newborns when they're here, to support that acute newborn call. I think Dr. Wagenek, Dr. joins us in July. Dr. Holly Dawson is doing yeoman's work, keeping the program going. We interviewed an FPOB and an OB in the last couple of weeks. But really the other pieces focusing on the delivery, I think would be short-sighted. The babies, we have to take care of, we have to have anesthesia. We've moved from having 2.6 anesthesia providers to, I believe, we're credentialing 13 anesthesia providers. So medicine is a team sport, it turns out. We've heard that before tonight. A lot of frustration and a lot of worry, though, about the fragility of that program. And 70% of obstetricians practice in a market where babies are delivered at the hospital with by laborists. So one person sees them in the clinic while they're pregnant. You go into labor, you go to the hospital, and all that person does is deliver babies all the time. We don't have that job in not in any rural setting. So, John, what was your?
Oh, sorry. Go ahead.
No, I was just going to say it was a very educational meeting. We are in a challenging environment, but it's crucial, obviously, we stabilize this and grow this program. But I think, like, looking at the financials, we had 17 births this last month, thereabouts. And so you don't know when the baby's going to arrive. So you've got to have somebody available at all times, and that continuity of care that Julie's talking about. So I just thought, I'm glad we had those sort of meetings. People need to be heard when the frustration's building, and that leads to hopefully creative problem solving. I know we came away with some lists of buckets that we're going to be tackling, and each one of them will hopefully lead us to an overall solution that works. But But I'm hoping at some point we go to the state and just say, look, somebody's got to deliver babies in this state, and the state needs to get more involved in making sure there's the resources to fill in the shortfalls from a financial standpoint, especially for the rural hospitals that just, but we're going to figure it out.
So you were saying about rural health, that it's just not how we can operate here, having the hospital as OB. Is there a thought that that might be what overtakes rural health ultimately in the future anyhow, or is that just not feasible regardless?
So Dr. Martin alluded in the presentation to the fact that many physicians are graduating thinking, I'm going to be a hospitalist. I'm going to work in the hospital, or I'm going to work in the clinic and I'm going to go home at 6 o'clock. I'm going to see my patients. I'm going to work hard, but I don't have any hospital privileges. That's for somebody who works 12-hour shifts in the hospital, like our hospitalists do, like these laborists do. So it is an urban environment where these folks are being trained. And I think some of the solution is I lean heavily on family medicine, where we are going to lean on FPOBs. So family medicine docs who deliver babies, just like Bruce Herman did for years here. That's not something you see in an urban and suburban environment. So, but it is really troubling, the fact that these medical students are graduating thinking they're going to pick between working in a clinic or working in the hospital. And again, we simply don't have that job here.
It looks like Dr. Martin has something to add to this. Dr. Martin?
Yeah, just to Julie's point, on average, we deliver about a baby a day. And on the average day, we never deliver one baby. But if we're going to have a laborist, and if we're going to have a NICU specialist, you're now talking about 24-hour coverage for maybe one event. And there may be days when there's no event, no reimbursable event. So theoretically, it's possible, but you would essentially need, and John, to your point, you would need the state to subsidize full-time coverage for the labor deck for every rural hospital. And I don't know that that's sustainable either. So Julie's right. We need a more flexible workforce. We need a workforce that can be productive in the clinic until they're needed in the hospital.
Dr. Martin, can you talk about the training you arranged for our family medicine docs?
Sure. And actually, one of our pediatricians took advantage of it as well, but we partnered with the Elson S. Floyd College of Medicine at Washington State University. They tried to come up with a longer name, but they ran out of letters. They go by FSCOM for short. But we partnered with Dr. Chris Martin, who runs their simulation lab. He brought out simulation materials. We set them up in our nursery and had our family medicine providers. Part of our residency, we do neonatal resuscitation, but we get in practice, and particularly the folks of my generation, it may have been 10 or 15 years since we did a resuscitation. The cognitive skills are there, but there's some mechanical skills that need some brushing up on. And so we're partnering with Wazoo to provide that for our docs. And I think it just adds to the drills that Stacy Botten does on a quarterly basis. Providers expressed an interest in having it on a quarterly basis. Washington State expressed an interest in doing it on a quarterly basis. So I think that was a great first step, but it was very, very well received.
Perhaps rural obstetrics, it's hard to say after rural, will stand on its own as a recognized specialty of need by some government entity.
There was a recent article about infant and maternal mortality that came out this week that really called out some creative roles, the doula, the certified nurse midwife, some things that we drifted away from. And also just basic preventative care that, making sure that we're getting blood pressures and and moms have access to nurses. And so a lot of boots on the ground things that we can do. But I do believe with we have 3 rural programs closed this year in Washington State. We have the attention of the state. And I think when we can bring forward answers and solutions like this simulation training that comes to the rural facility and brings your family medicine on board with acute newborn, I think that's the sort of thing the state is waiting for us to come forward with.
Well, thank you, everybody.
Other questions for Julie about the CEO report?
Well, Mandy, could you please explain what the term WAPI means? Because he was talking about our WAPI thing, and there's probably some people here that have never seen that term before. Could you please explain what
Quality-
WAPI stands for?
It's a CMS term and it means Quality Assessment Performance Improvement. It's an acronym for Quality Assessment Performance Improvement.
Okay, thank you.
I'll say what CMS means.
Centers for Medicare and Medicaid Services.
You have to explain it in terms of another acronym. Yes, thank you, Terry. Yeah, it's good to remind ourselves what these acronyms.
Sorry.
No, I appreciate it. Other questions for Julie? We also have a report here from Amanda, Resources. Andy, maybe in the future, we could get Amanda on the agenda. What the heck, we'll put her under Julie so that we're reminded of that.
I'm on day 3 back, so I'm happy to be back.
So that'd be great. Anyway, so there's her report. You guys have any questions for Amanda about her report?
Can you guys have ID?
Yeah,
Really? I was just being tongue in cheek.
Yeah.
Oh,
they
I
do.
need to hear
I don't know
from-
if they've been finished yet. I don't know if Michelle's on the line, but that is the goal. We had some samples made of Barrett and his picture.
I
So,
love it,
yeah,
okay.
yeah, people are,
Yes, Barrett has a name tag.
yes, yeah.
He's not in the payroll system.
Any other questions for Amanda?
Welcome back.
Thank you.
And one comment, and I am super excited that you were doing the experience healthcare again for those high school kids. That is so much fun for them and it's so informational. And you get kids excited about their future, about what they can do. So it's a really cool program.
Thank you. You've been very engaged, Sheriff, so we appreciate your partnership with the
Absolutely.
schools.
It's a great program.
How many attend?
I think we have 10 on the calendar for this year. I think we had a little more last year, but we opened it up to different schools this year. So we do have Kittitas, I think a couple, and then Ellensburg. And so people are really
Are you still taking applications or is it closed?
It's closed now, yeah, but we have talked about, different, we're getting it back up and running again, but maybe expanding it next year, or doing 2 different sessions, so.
Do they get to put in stitches or anything?
And talk about some simulations, I don't know what exactly is on the agenda, like some splints type of stuff, but there'll be a lot of presentations from our leaders and touring around facilities and just a lot of different representations.
They're going to be doing a little bit of job shadowing in specific departments.
Is it 5 full days, kind of, is that the way it works, kind of like a camp almost?
And not just in all kinds of clinical settings and
Yeah,
like.
not just nursing or.
Quality, all kinds of jobs in healthcare, like, so.
Yeah, but the helicopter always wins.
That's
I don't want to be a life flight nurse.
That's true. I don't want to be life flight nurses, but it's very cool. It's a very cool program and I'm so excited that it's still working and we're going through it again. So that's a great program.
Okay, then we also have Ron Erlacher giving us an update on the expansion project. Ron?
That report is on page 27. And the project cost is virtually unchanged this month, so there's nothing really new there. We've got a couple change orders coming up next month that will change that a little bit. So we're kind of under the current challenges through with a lot of those things that we've been dealing with the soil decontamination and the fire line and the flooding and the canopy that we had to get off. So that's all pretty much behind us now. And so a lot of that stuff will come off and we're going to start to see some progress on this. So start seeing some tangible things happen. We do have some piping. We've got a demo in the tunnel to make room for some new utilities. So I got to get that done. Because we don't want to box in other utilities that we're going to have to get to later. So got a little bit of that work to do. But yeah, next week they will be forming up the ramp by the loading dock. They're going to be putting in some underground drains and conduits on the west side. And they will be doing some pouring in kind of the big courtyard where the MRI was. And the fire line will be finalized next week. And they'll have the pathway complete for our fiber optics that went over to the internal medicine building. So that's kind of what's happening next week, and these things take off.
Questions for Rod?
So we've ordered GE MRI. Are we now have to do a little bit of redesign work now that we know what machine is going to go in there? Is there any architectural drawings that need to be worked up, or is that all taken care of?
And no, there are changes there. And we have the drawings from GE, and they're basically pricing the shielding and the utilities and everything based off of that. And they're now producing the final drawings.
Any concern, because I know it's kind of a rush to get, have it ready when the machine arrives and so forth. Does it look like it's going to be on track? Anything that makes you nervous about the overall, other than everything?
Yeah.
Anything specific?
Yeah.
No, I think we're going to be okay on that.
Okay.
Yeah.
And so that, in theory, that MRI could be operational before the entire project is done, or, okay, and operational in the sense we could actually use it for patients, or?
Yes.
Okay,
That's what I'm hoping.
as soon as possible,
Yes.
make that temporary one closed down.
Yeah, that's why it was important to get that ordered and to have that finalized so we could do the rest of the engineering. But I think we're going to make it.
Other questions for Rod? Thank you, Rod. Anything else for Julie before we move on to the CEO? All right, thank you, Julie. Next up, we have operations sitting in for Dee Dee Utley. We have Jeff Holdeman. Jeff?
Yes, so,
Can you just introduce yourself a
yes,
little bit?
yes, ma'am. Yes, ma'am. Jeff Holdeman, I am the medical surgical department director and the ICU director. I started work here in 2009 as per diem home health and hospice, and then transitioned into working ICU and med surg, and then transitioned into the director job in 2015.
Yeah, some of us did a gimbo with him. I forget which of us were there, but yeah, that was really informative. Thank you. Yeah, good to have you, Jeff. Thank you.
Thank you, sir. Yeah, so one of the big things that is coming forward in the fall from the YDC part is that if you look on there, you'll see that Peggy O'Neill's retiring. She has been a nurse here at our hospital for a long time, and she's been a professor at YDC in their nursing program for a long time as well. And unfortunately for us and for those students, she's retiring. It's fabulous for her, but it stinks for that program because she's just a great professor. And so we're going to miss her terribly. She does a great job with those students. So that's too bad, but hopefully they'll get somebody just as fabulous to replace her. So that's a big deal for them. And we hire so many people from that program. So it's a phenomenal program. So yeah, so there's that. And then as far as they're going to start rotating some nursing students, of course, through for sixth quarter, which will be fun. Just because of how YDC and Heritage work, their quarters are slightly skewed as opposed to like Central's quarters are set up. So because they have multiple start dates throughout the year. So it's a little funky. As far as the med surg and CCU side go, the admissions to CCU has slowed down slightly. And I'm struggling to find CNAs. So if you know somebody that's CNA and wants to work here, all those openings that you see they're all night shift. And those staff members that have left for a variety of reasons. So that's unfortunate, but I'm trying to recruit for that. I'm also working on 2 quotes to take to capital. One is for hospital bed and mattress replacement, and then also the house-wide Philips monitoring system that we currently have. We're working on getting a secondary quote for that to bring to the capital committee.
So you have looked at Mindray? Was that the other?
Yes, so the 2 issues with those 2 programs that I'm looking at is all that stuff is coming to end of life. And so it's a look at just kind of replacing existing equipment and updating a little bit from the house-wide monitoring system to take into the accord what's going on with the remodel and expansion project and SOP and OR and all that. So adding a little bit more equipment. Jim is doing well according to his staffing. So that's really nice. So Jim in the cafeteria is doing really well. And I know that the diabetes educator, Nicole, is busy all the time. So she's getting so many referrals. And that's a phenomenal program. So Amy's talking about, she's got some staffing challenges too, which hers is a little bit harder than mine because that's a really high-tech specialty trained area for the OR. So that's really hard to find those nurses. And so she's had some long-term travelers there, unfortunately, but she's being very hopeful that she can find somebody to replace those travelers.
2 or 3?
She has 3, I believe, right now. Yeah.
She's one of the few places, surgical services, where we haven't been able to wean ourselves off.
Yeah, I know that I think there's 1 traveler currently in the ER. I don't have any nurse travelers at all in either one of my department. I have CNA travelers, but I don't have any nurse travelers. And so that's been really nice. And just FYI, it's not on the sheet. We have been able to hire some of those travelers, kind of like what Dr. Martin was alluding to earlier, is that a lot of those travelers now don't want to do that anymore. And so thankfully, we've been able to hire a handful of those travelers that were doing rotations here, and they're now here permanently as part of our staff, which is really cool. We did. So that speaks highly of our hospital. If you travel all these places, and this is where you choose to stay. So kudos to the organization for that. The ER, that's pretty cool with their record-setting day, right? 49 patients a day. That's fabulous. So they just keep getting busy. Yeah, their ER is just crazy busy. And I was part of that interview team on the person that they're contemplating hiring as the permanent director. So we'll see how that goes. So I'm excited for that to happen. So, and I know Dee Dee is as well. So. And then Stacy, so when she's talking about the case management and revenue cycle, so what Stacy found, Celeste Tapia, who was the case manager, what happened with this was that Celeste went to Stacy at revenue cycle and said, I think we need to look at our charges because I don't think we're actually charging for items that we should be charging for on our patients. So we're potentially not billing appropriately. And so Celeste and Stacy in revenue looked at all their charges as a whole and went through it and identified areas where they were missing opportunities to increase their revenue. And there was also some challenges in delivery charges specifically. And they were also looking at documentation to support the charges and seeing what the nurses could document differently to support those charges so that we could actually capture those. So there's that. So that's a nice catch by Celeste in case management stuff.
Excuse me.
Real quick, on the 7 CNA positions, when I saw that, I went to the website and careers to see how this looked. I'm just curious, each one's kind of itemized, individual positions, some are full-time, some are part-time. I was just thinking, like, if I go to a restaurant, I pull up to the parking lot and it's empty, I think like, oh man, do I want to go in there and eat? But I'm wondering, when somebody looked at the website, and they're looking for a position, like, oh my God,
So-
do they have anybody working there?
So we do, thankfully. I mean, we have full-time NAC staff on day shift. And we do have a few night shift techs that are still working, CNAs that are still working, that's true. But what has happened unfortunately over the course of the last 4 months or so is that the nursing home here in town has skyrocketed their pay rate. And they're also doing a $5,000 sign-on bonus. So currently, our wages are not competitive. And I have mentioned this to HR, and I've asked them to do a wage analysis to see if there's something we can look at to do. Because currently our CNA wages start out about $17.30-ish dollars an hour. And Prestige is currently offering for their CNA starting there somewhere between $21 to $24 an hour. And so it's a sizable difference. And then they have that $5,000 sign-on bonus on top of it. And so right now we're not really competing for the same peeps. And because as you're aware, I'm sure, is that housekeeping and CNAs are typically one of the lowest paid employees in the healthcare organization. And what I was explaining to HR is that I understand that they come here and they have a lighter load of patients to care for. They don't have 30 patients on their floor, right? They have 12. So it's a somewhat easier job for them, but it's not about that for them, right? They're worried about $5.40 for a gallon of gas and $3 for a gallon of milk, and I'm paying $2,000 a month for my rent. And so they're going where the money speaks. And at present, our money's not speaking to them, unfortunately. And so I did ask HR to look at that and take a look and see if there's something.
This is a union position, though,
yeah.
right?
Absolutely.
So this is a Teamsters contracted position.
Absolutely.
And their benefits packages may be different as well.
Absolutely. I 100% agree with that. And I don't disagree with that. But as the lowest paid person here, you're concerned about paying your rent, not about what you're putting in your retirement. No offense. Because it's an instant issue, not I'm going to retire in 45 years.
We are
So,
definitely learning to be more nimble when we talk about market.
so anyway, so that's just a work in progress.
So when we have like part-time positions, there are people out there that would prefer a part-time, is that the theory? So you're letting them know. And so my general question was, instead of individual lists for positions like that, would it just be a general header of what it is and say, full-time, part-time,
So I can answer that too, is actually that's part of the union contract.
Oh, it
as
is,
well.
okay.
Yeah, we do have to have.
I knew there'd be a reason.
But to your point though, we've done that with MAs and it's been very successful
Yeah.
because those clinic managers can then do group interviews and sometimes they say, gosh, maybe it's a better fit over here based on their skill set. So we have done that in some areas.
We have tried that.
Yeah.
We did our first group interview with an applicant that had applied originally for ER, a CNA, that applied for the ER. And Jason, the intern that was here, knew that Stacy and I were both struggling finding these CNAs. And he said, what if I just schedule some group interviews with her and see which one she really thinks she fits into? And she chose OB. And Stacy was glad to have her.
And so the union contract, when does that expire?
Well, we just actually negotiated it.
This is one of the ones we just negotiated.
Yeah.
2024.
We did all 4 contracts actually last year, so everything was updated, but that's just how fast things are moving.
So how can the other place pay so much more? Is it a different union when you leave the campus here or?
Well, it's just a different market as well, a nursing home and assisted living versus the hospital, so
And I don't think the CNAs at the nursing home are unionized.
no.
Okay. Which why would you be if you get like $5 more per hour by not being unionized?
Well, there are many reasons.
No,
I can go into it. But, we don't have to do that in that. Right. Anyway.
Thanks, Jeff. Appreciate it.
You're welcome, sir.
Other questions for Jeff? Thanks for coming to the meeting and filling in for.
You're welcome.
Next up, we have Rhonda Holden, the Chief Ancillary Officer. Rhonda?
Yes, my report begins on page 31. And just a couple of updates there. We're delaying probably the armband for patients coming in, all patients. The implementation of that will be delayed just a little bit because there are so many people that are working on our PACS project that we haven't been able to take our eyes off of the PACS project and work on that. So it'll probably be September or after when we can get that off the ground. And then I just wanted to give a good recognition to Spencer Jarman and CT. If you haven't watched his YouTube video, I would really encourage you to do that. He's funny. And he was just really honored to be able to give an address at the pinning ceremony for the YBCC students that came. And it's just been wonderful to watch Spencer grow as he's worked with students and mentored them, and then to have them give the address. It was just so touching. Really nice. So I don't think I have any other updates unless you have questions for me.
Can you talk about the whole blood project a little bit?
Yeah. At the request of KVFR and Medic One, they were asking us to see if there was a way that we could obtain whole blood that they could keep on the medic units, both at KVFR and Medic One in Upper County, just in case of trauma patients with all the accidents that happen on I-90. It's been proven to be really beneficial in treating trauma patients who may otherwise lose their life if they don't have that whole blood. The program's running really successfully at Harborview, and whole blood is carried on a lot of the ambulances on the west side, and then also with Life Flight, the air ambulances carry it as well. So they were wondering if KVH could be the center and hub and process that. A couple of things: we don't carry whole blood, we don't use it in the organization at all. So that would be a change for us. I have reached out to the emergency department to see if they would like to start carrying whole blood for trauma patients, because we certainly don't want to waste any blood. There's such a nationwide shortage, you don't want to throw it away. And once you have it, you can't take it back to the Red Cross or wherever you get it from. The second thing we were wondering is if the medical director for Harborview Life Flight wanted to be the medical director for KVFR, and we're on the CLIA license for Medic One as well. And that way they could cycle the blood through Harborview because they're going to use it. You know, they have it for 7 days, and if they haven't used that unit, they take it to Harborview and they give it, so no waste. The other thing we suggested is maybe Dr. Horsley, our medical program director for our emergency services in Kittitas County, if he wanted to be the CLIA license holder to get the blood from the Red Cross or another organization, so that it didn't have to come underneath the purview of KVH, since there is some risk involved with that on our side if we did. We have very limited supply of O negative blood, you know, the universal type that anyone can receive, and the Red Cross has said that they will not increase our inventory of that, which is what we give here at the hospital. In such a situation of a postpartum hemorrhage or a trauma. So we can't help them in that respect, but it's a work in progress. So we'll probably be reconvening with the team and deciding which direction we go.
Hey, I know a guy at Harborview.
I know him too. He was on the EMS and trauma steering committee with me.
There you go.
Dr. Arbuckle.
Any other questions for Rhonda? Thank you very much, Rhonda. Next up, sitting in for Stacy Olea, Stephanie Walker. Stephanie, would you mind introducing yourself, please?
Of course. So my name is Stephanie Walker, and I am the Clinic Manager at Family Medicine Playell. So I am stepping in for Stacy while she is enjoying a well-earned vacation.
Thank you for making the drive down.
Oh,
all right. Take that back.
Counties. So my report starts on page 33, and my report is up to date. I did want to just let you know that Rapid Access, which opened up on May 1st, is doing very well. They're up to, between probably 16 and 20 patients a day. A little less participation on Saturdays. There are 4 to 6 patients, but marketing is working on getting the message out that they are open on Saturdays and are an extension of our clinics. And I would also like to invite all of you, or any of you that would like to participate, Emily Connery, clinic manager, and I would like to invite you to do a GEMBA with cardiology with Dr. Hoppy sometime in the fall.
Oh, yeah.
I've also invited neurology too.
Oh, wonderful.
Exactly.
Yeah, we'd be happy to do that, Mandy, if you wouldn't mind just making a note of that, please. What about, since we're talking about GAMBAs and rapid access, has anybody been by rapid access
As a patient or a commissioner?
as a commissioner?
Neither, but I would love.
Okay,
to as a
it
commissioner.
might be nice for us if there's time or room for us to sort of do a GAMBA, the rapid access.
Be with us to show you around.
Yeah, I know that was really, really exciting when that kind of running. So yeah, so I think we'd be happy to do it.
So this is Michelle here jumping in just as an FYI. We are starting to be part of the first Friday art walk, and that'll be at the MAC, and part of that coincides with rapid access timeframes. So if you want to think about that on your calendar, that's also another opportunity to check it out.
Oh, okay, great.
And Bob, I believe you were invited to the
Yeah.
90-day
Thank you.
review of rapid access operations.
Sorry to interrupt, Stephanie. Anything additional you'd like to say before we really with
Nothing else?
questions?
A question about the rapid access, is this? So the Saturday schedule is a little light right now. Is this an opportunity for people who have trouble getting to an appointment in the week to seek non-urgent, just routine care on a Saturday? Or is it really reserved for people who would prefer to stay out of the emergency department if possible, but need to be seen?
So the care is, it's, what we're trying to do is we want to support access for our patients. And so rapid access will, see anything from, strep throat to, lacerations to maybe, possible strain or sprain. But we are doing things like roll-in visits and those types of visits.
Think about things that are kind of in the middle that aren't necessarily routine prevention, but aren't necessarily incredibly acute. But I guess that's something that could be determined when someone makes a call to schedule that to see if it's appropriate for the rapid access. All right.
What we found was, and again, this has been a soft roll since May 1. But the clinics immediately, the triage nurses were able to say, I can't get you into Dr. Merrill Stesko, but we have appointments available in rapid access. And just knowing, it's the KVH family of care. You have the record there, you have a KVH provider, you know that the information is getting up to your primary care doc. And if there is a need for a follow-up appointment, it's made while you're there. So that's why I think Saturday hasn't really caught on the way we think it will once we really start telling people, if you have that earache, if you have questions, rapid access is for all of KVH. So, with the exception of women's health, correct? All right, so no women's health. The pregnant ladies scare.
It's women's health, but not obstetrics. Is that appropriate?
Yeah.
for-
Yeah.
Other questions? So Stacy always she always reports on all the clinics and things, but since you're here, how's everything going up at Family Medicine for Yellow?
Everything is going great up at Family Medicine Yellow. As Julie mentioned earlier, our behavioral health care program is doing fantastic. Primary care is busy. We are, of course, have big news.
We have Brett? Yes, go ahead.
Okay, I can announce this then. We had a fantastic interview with a DO who is currently doing her residency and will be graduating next June and available to join our team in August of 2024. Like I said, the interview was fantastic. We did a tour up in Clayellum and she signed her paperwork earlier this week. So
She was a fit. We all went, this just feels right. This feels really good.
Is it somebody who's graduating and appreciates the rural healthcare needs?
And she was thinking about doing an obstetrics fellowship because she really likes babies. And she said, if I come work for you as a family medicine doc, can I please do acute newborn? So it was a click, and I don't know if you know, up in Cleveland, when they interviewed somebody, they have a potluck sort of survey that they do. You have to have the right answer on it. So they have a very unique way of picking staff to work at there, but I was really enthusiastic about this.
When you say a potluck survey, is there actually food?
We did actually have Rob Burkle, our PA, they happened to make a gorgeous carrot cake that day, which she enjoyed. I think that was the tipping point for them.
But they go through some, at a potluck, do you bring barbecue or, and if you get the answer wrong, it's like, get the cold shoulder.
All right. Well, anything else? Thank you very much, Stephanie. Appreciate it.
Thank you.
Next up, we have our Chief of Staff, Dr. Hoppy. Dr. Hoppy.
Yeah, well, thank you. Two items on the agenda. I think I'm on page 38 and 39. So the Medical Executive Council had another busy month with credentialing. We had 6 people up for initial appointments and 10 people up for reappointments. Most of the new appointments were ER providers and 2 are on-rads. And the MEC recommended approval of the list here and presented in front of you.
Everybody's had a chance, I assume, to review these, the online system. Are there any questions or anything for Dr. Hoppy about any of that stuff before we make a motion?
Just wanted to confirm if there are conditions that something be removed from our privileges because we don't do it here or something to that effect. And MEC members say approve with conditions. I can't remember how it's worded on their response. Is it appropriate for board members to just say board approve, understanding that that will be the condition? Or I just want to know where it comes, what I'm approving, do I need to be approving with those same conditions? Does that make sense to everybody?
I think I understand what you're saying. If I'm getting your question wrong, let me know. So when we say board approve during our review in the online system, and when we approve it here, we are approving it with the conditions as stipulated by MEC, correct?
Correct. That's my understanding. You're approving the recommendation of MEC.
Right.
So we don't need to specify approve with conditions because that's
correct.
taking place. Okay, all right, thank you.
Does that mean that the MEC approval had a condition and somebody wrote a note? I think we're talking about the same thing.
Correct.
So if that note is in the MEC approval, our approval is just approving that we agree
With the condition.
with the condition that you, MEC, will take care of that condition as part of the process.
Correct.
I can stop my click hesitation as I do this. It's fine. Okay, thank you.
The second part here.
Sorry, we have to take.
Oh, I'm sorry.
take a vote
Sorry,
on
I'm
that.
jumping ahead.
Any other questions before we take a vote? Do I have a motion to approve then the initial appointments and reappointments as indicated in this list?
Approve the appointments and reappointments.
Okay, moved by Erica. Second by Bob. Any further discussion? All those in favor, please say aye.
Aye.
Okay, thank you, Dr. Hobby. Your second.
Yeah, thank you. The second piece is a new delineation of privileges that was presented by the department chair of emergency medicine. And it's a point of care ultrasound for the emergency department. As you know, the new ER doctors really have been trained adequately in the use of ultrasound. And so they want to be able to implement that, I believe, in January coming up this coming year. And so this DOP was reviewed by MEC and also we approved it as a whole.
And this needs to be approved by the board, I see. Are there any questions for Dr. Hobby about the delineation of privileges?
We'll make a motion to approve.
Okay, we have a motion from John,
Second.
Second, Terry. Any further questions or discussion? All those in favor of approving the delineation of privileges as put forward by MC, please say aye.
Aye.
Thank you very much. Any other questions or anything for Dr. Hoppy? Dr. Hoppy, you have anything else for us?
Nope, that'll be it.
Wanted to say that I really like the abbreviation of focus. It's a fun one.
Thank you very much, Dr. Hoppy. Next up, then, we have Dr. Martin, the Chief Medical Officer. Dr. Martin.
You've probably heard enough from me tonight. You have my report in the packet, and I'll take any questions.
Any questions for Dr. Martin? Apparently, the board agrees with you, Dr. Martin. All right, thanks a lot, Dr. Martin. Appreciate it. Next up, then, we have CFO Scott Olander. Scott.
Thank you. I'd like to just start off as we announced last board meeting, Kelly Gooding, our Director of Finance, is leaving, and I wanted to let you know what Jason has got a very good plan about how we're going to work through that departure. So Jason, do you want to step in and tell us?
Yep. Can you guys hear me?
Yes.
So yeah, Kelly's last day is tomorrow. Starting Monday, we wanted to give a little bit of time to just let the dust settle after she leaves, and then try to just reevaluate the position in general and the job description and duties and define those really well. So starting Monday, though, Libby Allgood, who you probably all know, will be coming on part-time to help fill some of the gap while Kelly's gone. So Libby's gonna be up at Radio Hill. She'll be in Kelly's office about 20 hours a week initially, and she's just gonna help it evaluate the team, the department, and just keep the momentum that we've been working on the last year. So that's the plan with that. And then hopefully in the next 4 months or so, we'll have a permanent position posted.
I think this really makes a lot of sense. Yeah, Libby knows the organization and knows the team up there. And so I think this is really well thought out and good plan.
Yep. I just appreciate Kelly's timing too with this. She waited till she finished the audits for all 4 entities, finished the state audit, and we finished the cost report all as of May 31st. So it's really good timing that she left us. We're in now kind of the accounting periods, kind of lull period, I guess you could call it, to take this time and really evaluate the role.
Thank you, Jason. If you just turn to page 45, which is our statistical page, and lines 1 and 2 continue to be below budget on admissions and patient days. The shortfall down on deliveries is a factor and a part of that shortfall, but also, as we said, Dr. Longo is doing his total procedures on an outpatient or observation basis. And so our overall revenue is up, but it is shifted from inpatient. And if you'll note down on line 2 and then on line 21, our equivalent observation days for the month is over budget, and year to date, the observation days are over budget by 249 days. And line 2, our inpatient days without newborn is below budget by 322. So it's almost up. It's not a straight 1-to-1 offset, but it is offset. So that explains the revenue variance on inpatient. Line 6 is very encouraging. Our average length of stay is 3.6 for the month. And that is important because we need to keep it at 4.0 below, just 96 hours. As you've heard, ER is very, very busy. You see that we're.
Sorry to interrupt, Scott. We need to keep it below 4.0 because of our designation.
Correct. Critical access hospitals. Yeah, that's exactly correct.
Thank you.
And you see on line 14, ER visits are over budget for the month and over budget year to date, and that over prior year, we're at a positive variance of 17%. So the folks in the ER are working very, very hard on lines 12 and 13, our outpatient surgery procedures and GI procedures well over budget and very positive trends. Then
On the ER visits, is that over budget a little bit because we're getting people from out of Kittitas County coming here? Is that why it's over budget?
That's part of it. We have, I think, about 85 patients on the last couple of months on average are coming up from Yakima. Choosing to come to RER as opposed to going to Yakima.
I think it's just good to have that announcement made. So people know that our ER visits are going up because we're getting people from out of Kittitas County coming here.
Some of it also is, we have Dr. Martin has recruited Yakima emergency physicians. In addition to our employed ER providers, we have a contract with Yakima emergency physicians for the shifts that our doctors aren't working. And they're well-respected doctors and people know that they're here and they're choosing to come up here to see these doctors too. So that's.
I talked to some of the providers in Yakima recently, and they said it would be helpful if, like on our website, we indicated the waiting time for our emergency room in real time. Because often Yakima is backlogged, and so people are having to call, and people are having to take time out of their day to say, hey, how's it look there? Because they're happy to come here, like you said, because they know some of these providers, but it makes the decision so much quicker if they can say, okay, Yakima is 2 hours and 3 minutes to be seen, Ellensburg 7 minutes or something like that, if we're looking for more customers.
I would say this, we need to be careful with that. The state really frowns on.
Really questionable, and Yakima that's encouraging people to go to the emergency department, and the state will come knocking on the door.
All right, I knew it was too good to be true.
You're not supposed to pick and choose your
But I think the word is out, though, even without that information not being posted and publicly available, that the wait times are less in Ellensburg than they are in Yakima. So that I think people have experienced that and come here probably for that reason. Just on clinic visits, a little bit below budget. Did I mention diagnostic imaging on line 17? Over budget for the month, over budget to year to date, and trending upward. And that's really important to realize that diagnostic imaging, particularly with MRI, CT, that drives, that's a significant revenue driver.
An MRI, the one we currently use, is not nearly as efficient as the new one will be. So in theory, we'll have higher throughput with the new system when.
Yes.
Okay.
Probably 30 to 40% more efficient.
Because it's not a shortage of patients, it's just a shortage
Right.
of time on the machine.
Yes, it is.
Machine's available, okay.
Yeah. So that's a brief summary of the stats that we have on.
Can I brag on the management, the operations management team on line 36 and 37, if you will note. Our charges per adjusted patient day in 2023 are under budget, but also running below where they were this time last year. So our cost per adjusted patient day is lower in 2023 than it was in 2022. And I know I like to remind the board just how cost conscious our operations managers are. And they are just to squeeze every dollar out of operations that they can. But to have a year-over-year decrease in cost and decrease in charges to the patient is pretty outstanding.
And are these actual costs or normalized? Because sometimes Jason normalizes
These are
things to make the dollars equal.
These
are actual.
So any questions about page 45? I would like to jump over to just page 46, and this is the stats again, but it alludes to the growth that Dr. Martin was talking about, particularly down on line 22. You look back in 2016, our 48,525 clinic visits, and now we're annualizing, we're trending at 92,108. And then on the surgeries, line 9, we're trending at 2,347. And back in 16, we're at 1,510. And then ER visits for many, many years, we were hanging around 14,000 visits, and now we're trending almost to 17,000.
With the surgery, though, we also have kind of a choke point there, do we not? I mean, as the expansion finishes, anesthesia comes on board, that will free up some potential backlog there. Is that an accurate statement?
That is an accurate statement. And that
Yes,
is,
there you go.
That's an affirmative.
Yes, John.
okay. So anyway, it just, the organization is really growing.
There's turnover, but overall, we're growing.
There is turnover, but we are growing. So if you'll jump over to now page 48, you'll see the reflection of the stats that we were talking about in the financial statements. Negative variance on inpatient revenue, positive variance on outpatient revenue, and professional fee revenue. Overall positive revenue variance for the month of 598,000. Year to date, positive revenue variance of $5.3 million. The other operating revenue was is particularly notable this month is a couple of months ago, Nassar, we decided to start with the 340B ESP program. We were elected to do that a year ago. We're starting to see recapture some of that 340B contract revenue that we have. There's a little bit of retro in this number, but anyway, it was the biggest jump that we've seen for quite a while. And so I was really encouraged with what we're seeing there. And then just out, the other outpatient pharmacy revenue was up nicely also, which helped us hit that positive variance for the month. Overall, expenses were over budget by $89,000. At the finance committee, we noted that we've been really focusing on temporary labor. This $182,000 is a bit of a catch up as some of the invoices came through. As Jeff had noted and others have noted, we are weaning ourselves with Accepta surgery on a lot of this temporary contract labor. So that's a bit of a catch up on the finance side, but not all in all, it continues to be a positive trend. For the month, we had an operating income of $765,000, and we had a net for the month of $892,000. We're still a little bit behind, or we are behind budget year to date, but trending in the right direction. And if we can just bump up, not all of those are pretty good financials. Not everything's 100% rosy.
Scott, real quick on the bond money that we have invested.
Yes.
We have caps on what we can earn. Are we over that? Are we earning too much with that money? I mean,
yes.
And what happens to that difference?
We'll have to either refund it or I'm not. There's
no penalty, right? It's like you just now you got to also pay a penalty. You just got to give the difference back.
It's called arbitrage, and it's a complicated averaging.
Yeah. And it's not, like I said, it's a complicated, we actually have a consultant to do the arbitrage calculations. And
So it can offset some of the loss in the own.
So our bonds are tax exempt, so we got a lower rate because they are tax exempt. So what they don't want you to do is go out and take out all the tax exempt debt and invest it in the stock market or invest it and earn a big return on it. So when you have tax exempt bonds, they make you look back and say, if you earn more on that money than you paid in interest, then again, as Scott said, there's a very complicated way.
And we are earning our borrowing rate for that 2022 debt was 4.05%. We're earning about 4.5, 4.6 on that money. So there's.
And how much are we going to pay this consultant to tell us how much we have to put back?
Not much. It's
okay.
Not a whole lot. All in all, our days in accounts receivable are ticked up a little bit, about 3 days. We've got a lot of medical leaves in our rev cycle team. We're doing some juggling to compensate for it, but we're struggling. We've got Tara's working through it. She's working really hard too. But all in all, the payer mix continues to be good. Self-pay is at 1.43. So all in all, a good financial issue for the organization. Any questions?
Questions for Scott?
Okay. I would like to bring your attention on page 53 and 55. As you recall, Medicare took back about $260,000 of COVID test payments that we were using the BioFire 22 target test for some of the rapid tests that we had to do in the ER to decide whether or not the patient was positive and where to put them and how to care for them, or to whether or not they could be transferred to accepting hospitals, and insisted that we have test results before they would make a decision on whether they could take the patient. So we sent an additional appeal letter on June 9th of 23, because we had heard nothing from our letter that we sent in back in November. And it was sent certified mail. Have not heard back from Meridian yet. Julie has shared this information, our frustrations with the American Hospital Association. They suggest that we reach out to Region 10, the CMS Region 10, which I did. And we got an email back from the administrator of Region 10 within 24 hours. And then she referred it on to somebody else, and I got a response back from that individual. So it is in a queue. I don't know that we're going to get a satisfactory answer, but at least we're hearing from people. And they may put some pressure on Meridian to relook at this.
But our patients will not be responsible for.
That is correct.
And as long as they follow the rules we put out. So we'll eat that if we lose this.
That is correct. And we did send out a letter to the patients that were receiving statements, and reassured them that that was the case. So there was communication directly to patients, and that letter is also on the website. And then questions about that? Then Mitchell's report about he is applying for a variety of grants. Don't have any definitive answers yet on them. Page 59, we have a capital request to buy some exam tables for Dr. Fang and Dr. Hoppy and Dr. Gustafson's office and over in internal medicine. And the finance committee thought it was a good idea when we got a personal letter from Dr. Fang.
Anything, John or Bob, that you guys want to talk about? Having talked about this in the finance committee.
No, seems like a pretty easy decision. Yeah, they have a lengthy life. As our patient population gets older, the adjustable bed makes it both easier for the patients and the provider to get them comfortable safely and be able to do the exam. So after a discussion in the finance committee, we unanimously agreed we should definitely move forward. So that being said, I would move to approve it if there's further discussion over that.
Okay. John makes a motion. Any second? A second from Erica. Any further questions or discussion? All those in favor, please say aye.
Aye. Thank you very much. Lastly, it's not in the packet, but I wanted to give you an update about our communication with Alliance and what we've done with MRI. We received a letter back from Alliance, from their attorney, their corporate attorney, basically accepting that they're willing to end the contract with our mobile MRI on May 1 of 2024, which is exactly what we asked for. And that was that. And so our Brad Berg has drafted an addendum to the contract that basically formalizes that. And so that has been sent off to their attorney, and hopefully they'll sign it and we'll be done. And then we have placed an order for the GE MRI that is going to come.
So part of the reason that we stepped away from that contract was because they were not providing the service and the level of quality we needed. But they caused a delay of about 4 months, which has potentially real cost to us. Once this is settled with the future contract, is there any chance, once we see some of the numbers of what it costs us to have that delay, we talk to them about additional compensation, or is that a conversation for another day? Or not at all? You believe at that point?
I don't believe
We're
that's
just done.
realistic. We could approach them about that. But I don't believe, it wouldn't be worth the legal. fees
Bringing a bunch of
and that.
lawyers in is not going to make this a better problem.
No. I
So.
don't think so.
So that we feel like hopefully we'll have a signed letter back from Alliance. And we will know that we're completely done.
Great.
And that is all that I have. Any questions?
Questions for Scott? Thank you very much, Scott. Thank you, Jason.
Thank you.
Thank you, Kelly.
Okay, next up, Michelle Worrell on the Community Relations Report. Michelle?
Hi, you got my report in the packet and I don't have anything new to add, but I would be happy to take any questions.
So the fitness fair, another, it's gonna be outdoors or indoors next time?
I'm pretty much betting it's going to be indoors.
It was exciting,
It is. It was a good event.
but I know that the people I talked to, for the most part, got a lot out of it. A lot of them were surprised they got stuff out of it, just visiting all the different vendors and hearing things that were available to them in the community. So thanks for putting that on.
Oh, of course, and it's been a lot of fun. Like today, the team was out at the Touch a Truck event because there was also a bike rodeo. And so I think they said like they brought something like 80 backpacks. Every single one was gone. And there were more people and people were really enjoying. It was a younger crowd. And so the parents were using this as the opportunity of, this is where your doctor works and things like that. So it's just great being back out at a whole bunch of different levels.
I just want to thank Michelle. I don't know if you're aware that she's one of the public information officers up in Grant County, as well as functioning in that capacity at KVH. But she reached out to us during the active shooter event up at George and let us know so that we could inform the house supervisor, get in front of it with the emergency department. So it's really nice to have Michelle plugged in up at Grant County as well. So it was nice to have that heads up. It's nice to be able to assure the staff that we're aware of what's going on.
Any other questions for Michelle? Go ahead.
Michelle, is the new name Adult and Internal Medicine written in stone?
Internal and adult medicine. And no, we haven't etched it yet.
It seems overly complicated versus just adult medicine. I get what you're trying to capture, but we have family medicine, then there'd be adult medicine. So again, that's my 2 cents, which you were not asking for, but when I read it, I was just thinking, seems more complicated than it needs to be. So,
I did not pay him to say that, Michelle.
oh, did you have a similar thought?
It actually is more complicated just with the billing and things like that.
Thank you, Scott. I would agree with you, but I don't get to make sole decision on this one because of reasons that Scott alluded to.
Okay.
Neither do I.
Okay. Neither do I.
But it shouldn't be that complicated.
It shouldn't be, no.
Other questions or comments for Michelle? Thank you, Michelle. Appreciate it.
Thank you.
If there's nothing else on the reports and dashboards, education, we have the Rural Hospital Leadership Conference being put on in Chelan. Many of us are going to that. And then there's the HA Leadership Summit in Seattle, July. Many of us are going to that.
No, it's Ulan.
Yeah. You fixed that.
I can over.
Yeah. So If you guys have any questions about planning for that, please talk to Mandy Weed. Nothing in old business, nothing in new business. We'll be going into executive session. Julie, how long?
AJ, did anybody find the agenda? I had no luck. I feel like I found it once online, but not find that link again to that agenda unless I'm completely imagining.
Leadership's on it for leadership.
Yeah, in July.
Didn't find that. I think it is.
I sent it out in the email Friday, I think. Yeah, I can resend it to you though.
Yeah, thanks,
Okay,
Mandy, if you
thank
wouldn't
you.
mind resending that. Okay, so we just need 15 minutes, so let's take just a 5-minute break at 7:30. And we'll have a 15-minute executive session and plan to reconvene after that.
Action.
No action will be taken. Thank you all. And we'll break then and then go to executive session. Thank you.
Thank you, everyone.